My name is Christina Eloy. I'm a medicine clinician in the equine hospital, and I also specialize in cardiology in horses. So this is actually my favorite lecture. I hope there will be yours as well. There's quite a lot of things that we're going to go through. I uploaded some notes for you, and before you ask, I am going to give you the slides. As well, I am going to just take out all the things that's not relevant. Okay, so today in the lecture I would like you not to look too much into your computer, but focus on what I'm saying. We're going to do some cases. We're going to make it a little bit interactive. I'm going to try at least to make it a little bit interactive. Okay. You have a lot of resources that you can use. So you've got these cardiology notes. There's two different ones, 1 and 2, okay, so on ClickUp, the 1 is all about the clinical examination of a horse with potential cardiac disease, and the second one is about the specific diseases. We're obviously going to go through all of that today. There is a few things at the bottom, but I will have some slides at the end that I will not cover in the lectures, just because it's rare in horses. We don't see that commonly, but I have covered it in your notes, and it is also part of knowledge that you should have for tests and exams. So don't only rely, please, on the PowerPoint presentation, but it does say at the end, self-study, this is the topics that you need to know, but it's not much, okay? It's only like 2 pages in the notes that you would have to read on your own, that we're not going to talk about today. If you are interested in more detailed literature, you have your prescribed resources, as you see here. Okay, so the equine medicine book, the Robinson Current Therapy in Equine Medicine, chapters 120 to 130. Obviously, you don't need to go through all of that, but if you want to know something in more detail, this would be the right literature to consult. In addition, you'll see there is a consensus statement. I'm going to every now and then talk about that a little bit. So this is where experts get together and they come to a consensus about current recommendations, how we should handle diseases or certain horses cases for certain diseases. So it's a good one to consult. It's not a long paper. It's like this one here, recommendation for management of equine athletes with cardiovascular abnormalities. There's also a book. This is just now for your interest, okay? So it's not something that you need to know for tests. But if someone is interested in cardiology in the horse, there's actually a book, Cardiology of the Horse, that's written by Celia Marr. And then there's also, if you know, Veterinary Clinics of North America, Equine Practice, which is a journal that comes out on a regular basis. They have like an edition which just covers cardiology in horses. So if you would like to look at any of that, you can. But as I said, this is not necessary for tests. This is just for people that's interested in the topic, okay? Or if you at some stage in your career get a horse with a cardiology problem, then at least you can go back to your slides and know where to find info. Okay. So what we're going to do today and tomorrow, I guess, is we're going to talk about equine cardiology just in general. We're going to talk about what an equine cardiovascular patient will look like, how we're going to do an examination in a case where we suspect cardiovascular disease. We're going to talk about cardiac murmurs and cardiac arrhythmias. So that's like the 2 most common findings in horses with cardiac diseases. When you listen to the heart, you hear a murmur, an abnormal sound that you shouldn't be hearing, or you hear an irregular rhythm. And we're going to talk about cases with heart failure, which is very rare in horses. That's why we're going to focus more on these cases here that have murmurs and arrhythmias, but they're actually clinically completely fine. So we're going to go through that step by step. So let's start with some facts. The horse's heart is one of the most efficient pumps found in nature. Okay? Few animals can actually match the efficiency of the horse's heart. And you can see just look at heart rate, okay? Like a normal heart rate in the horse at rest is 28 to 40 beats per minute. But when they exercise, at maximum exercise, the heart rate goes up to 220. It shouldn't go higher than that, so that's the maximum, but it does go up. And why does it go up? Because the horse needs to increase its cardiac output, which means the blood that is ejected out of the heart per minute, okay? So the total volume that is going out of the heart per minute, or basically flowing through the heart. And at rest, that's about 40 liters per minute, okay? At exercise, it goes up to 300 liters per minute. So that's quite extraordinary if you think about that the normal blood volume of a like normal size horse, like a 500 kilo horse, to a standard like thoroughbred, is about 50 liters. Okay, so they can circulate their whole blood volume 6 times in 1 minute at maximum exercise. Okay, this is why they are so efficient, why they are such good athletes, because this is how oxygen is obviously transported to where in the to the peripheral tissue, especially to the musculature. If you think about the racehorse, for example, okay? And we do know that horses with greater or larger hearts have greater athletic ability. So the better the heart is, the better they will perform. So what are common problems that we encounter in horses that have a cardiac disease? So as I have said at the very beginning, it's heart murmurs and arrhythmia. So murmur is like now you listen to the heart, and you usually, like we're going to go through that just now again to remind you, but you should actually all know how to do a cardiac auscultation already from your practicals, where you listen to S1, S2, your heart sounds, and now you hear like an additional sound which shouldn't be there. That's called a murmur. Okay? So that's a common finding in horses that are completely normal. Okay? They don't have any other clinical signs. The same for arrhythmias. You can listen to a horse's heart that is like, let's say it's coming in for lameness examination, but it's otherwise completely fine, and all of a sudden you hear an abnormal rhythm. That is common. We see these kind of horses. We do not often see horses different than in small animals that actually come with clinical signs of heart failure. Okay, it's very rare in horses. But these murmurs and arrhythmias are still significant, even though they don't make the horse necessarily sick. Okay? It's because horses with these signs can have structural heart disease. Okay? So there's something wrong, obviously, with the heart, but they can tolerate that disease very well. So it doesn't affect their performance, it doesn't affect their life, their quality of life, and they are still fine. Progression, so any heart disease can progress, okay, and progression into heart failure is rare in horses. Okay, so not like a small animal where you see that more commonly. In horses, heart failure is very rare. But, and here's the big but, okay, so this is why cardiology is important in horses still, because like now you might think, hey, if I'm saying like, okay, they have these diseases, but it doesn't actually make a difference to the horse. Here's the big but. Heart diseases can cause poor performance, so that's important in any horse that's used for any athletic use. And more importantly, they can have collapse and sudden cardiac death. So maybe if you've seen on television every now and then, you have like a race horse that collapses and dies, okay, or that can also be a horse in the paddock that all of a sudden you find dead in the paddock. These horses very likely have had a cardiac disease that was never diagnosed, okay? Because they don't cause any clinical signs until something like that happens, the horse collapses. If you sit on the horse when that happens, very dangerous, okay, for the rider. That's why cardiology is important in horses, although it often doesn't cause any clinical signs and the horse can tolerate it well, they don't have any pain or otherwise abnormal. Unfortunately, our treatment options are very limited in horses. Okay? You can't do open heart surgeries, you can't do valve replacements, medication is very limited what we can use in horses because horses are huge, they need high doses, very expensive. You would use the same medication that you use in humans and in small animals. If you use it for horses, it's very expensive. And actually no proven studies that it actually makes a difference. Okay? So treatment options limited. There is a few diseases that we can treat, and we're going to talk about it. Treatment quite cool, much more fun than in small animals where you just give like medication. So when we assess horses with cardiac disease, okay, we have basically two goals. That is, we want to know if the disease will impair athletic performance, because a horse is not a pet, okay? A horse is used by the owner, the rider, for activity. Say it's dressage, show jumping, racing, endurance, like it might be a pleasure horse, but it might affect the performance of the horse. And we want to know, is there any risk to rider safety, which means like, can we actually say, no, the horse is okay, there's no risk in riding this horse with a heart disease and it can't collapse and have sudden cardiac death. We do not talk about heart attack in horses, okay? A lot of people will say like, yeah, like not a lot of people because it doesn't happen often, but people will say that had a horse that like suddenly died, it's like, yeah, the horse had a heart attack. Okay, a heart attack in that sense, like we use that term in human medicine, doesn't exist in horses, okay? In human medicine, you have like the clogged arteries, and you actually get necrosis, or like a completely different pathophysiology that causes a heart attack. Horses don't have that. And a horse has sudden cardiac death. It's usually associated with an abnormal rhythm, okay? Like an arrhythmia that causes ventricular fibrillation, for example, that makes the horse collapse and die. But we're going to get to that a little bit later. This is just like to give you a bit of an overview about what cardiology in horses is about. Okay, so I did say to you that like the most common cases that we see have actually no presenting complaint. So we have an incidental finding. You know, you go to a horse for, let's say, vaccination. You should be listening to the heart and like do a physical examination at that time. It's not always done, but should be done. You find an abnormal cardiac auscultation, so you hear a murmur or an arrhythmia. That's most commonly. Or the horse presented for something else. Happens to us in the hospital all the time. The horse is coming in, let's say, to have a gastroscopy because it has recurrent colic, and you listen to the heart and like, hey, this horse has a heart murmur. Did anyone ever notice that this horse has a heart murmur? So that's your most common patient. Okay? No presenting complaint, clinical exam completely normal. It's just incidental. You listen to the heart and we find an abnormality. That's why the owner usually does not notice if a horse has a cardiac disease or not. Okay? We talked about poor performance and collapse. So some cases might present for poor performance. Okay, so the owner will say, no, my horse is not like performing well, like it's like a race horse might finish last, or if you have a show jumper, they might knock over, where they usually don't do that. Or you could even have like a presenting complaint or like a history where owners would say the horse actually had an episode of collapse. It's like a syncope kind of thing, so when they go down, but then they get up and they're fine again. So those horses can also have cardiac disease, but importantly, horses with poor performance might have other diseases as well. Okay, that's causing poor performance, not necessarily a cardiac disease that does that. And then very rarely we see horses that present with actual signs of heart failure. Okay, and this is often cases that have had a cardiac disease for a long time and they progress slowly and no one's ever noticed that until they go into heart failure. Okay? Alright, so when you do your physical examination, as I said, in a routine patient you actually don't find any abnormalities. Okay? So normal respiratory rate and effort behavior is completely normal. You might, when you feel the pulse, you might feel an abnormality, but often also normal. But remember, like if it has an abnormal rhythm, you will also feel that abnormal rhythm when you just palpate the pulse. Mucous membranes, everything normal, jugular veins normal. Ventral edema is something that we commonly see in horses that have heart failure, so definitely don't have that. As I said, most important is your cardiac auscultation. That's where you actually find the abnormality. And performance can be normal or abnormal, but as I said, not all horses with poor performance have a cardiac disease. More commonly, they have something else. Just to talk about poor performance, now we talked about cases that have actually no presenting complaint, just an incidental finding. And then cases that actually present because of poor performance. So important, musculoskeletal and respiratory diseases much more common than cardiac diseases to cause poor performance. Okay, other things like metabolic, gastrointestinal, neurological diseases can also cause poor performance. So if you do a poor performance workup, there's often a lot of examinations involved here. We also found recently actually that equine asthma and gastric ulcers are the most common causes of poor performance. So cardiac disease is really not your most common, but if you have a horse with poor performance and you listen to the heart and it's abnormal, then there's a good likelihood that there is underlying cardiac disease that's causing the poor performance. Okay. So remember, poor performance can be caused by cardiac disease, but not all cardiac diseases cause poor performance. Okay, and poor performance can be caused by all sorts of things, including cardiac disease. Okay, is that clear to everyone? Right. Okay, again, I know I'm repeating myself, but I'm doing it on purpose. Most cardiac patients are identified during routine examination. They do not show any obvious clinical signs at rest, except for an abnormal finding of cardiac auscultation, which is murmur and arrhythmia. Now, I'm repeating myself because we're going to talk a lot about murmurs and arrhythmias now. We're going to talk about murmurs and arrhythmias in horses that will otherwise not have any clinical signs. Okay? Alright, so now you have a horse that you are looking at for whatever reason, and you find an abnormal cardiac auscultation. Now what you need to know, is it a young horse, is it an older horse, because like young horses might have congenital abnormalities, there's certain diseases, cardiac diseases that's inherited. Older horses can have degenerative diseases. So it plays a role just to think about what kind of disease you might be looking at. Breed, like there's predispositions for certain diseases. Very important, what is the horse used for? Because your recommendation at the end of the day is very much dependent also on what the horse is used for. The cardiac disease might have no influence if it's a pleasure horse, but it might have a huge influence if it's a race horse. And like you're saying, it's maybe a young horse that's supposed to be a racehorse, they're training it to be a racehorse. Now you're finding an abnormality in cardiac auscultation. Now the owner's going to ask you, well, can this horse still be a racehorse at some stage? Can I still train it? Should I put like an effort and money into this horse to train the horse to become a racehorse or not? So you need to know these things to be able to make a prognosis. Then performance, obviously, if the horse hasn't any reported poor performance, it's always good to ask, are you sure your horse is performing well? Like, what are you doing with the horse? You might have like a pleasure horse that the owner says performing well, but actually if you would now like do more intense exercise with the horse, you would actually find that this horse isn't suited normal, like it can't do that kind of performance. And then you obviously want to know when it started, if it had poor performance. Always ask if a history of collapse was present, or if there was any other concurrent diseases present. Okay. Always perform a full clinical examination. Okay, don't just focus on, okay, I'm going to listen to the heart and that's it. Always a full clinical examination. Okay, but we're going to, you know how to do a clinical examination, and as I said, other than cardiac auscultation, the clinical examination will be normal in these kind of patients, so we're going to just focus now on cardiac auscultation. So when you do cardiac auscultation, you're going to obviously count the rate. We're going to listen to what heart sounds we hear. There's 4 heart sounds that you can hear, which is normal. Then we're going to think about the rhythm. Is the rhythm normal? Is it regular? Or is it irregular? And we're going to think about, are we going to hear anything else other than what we're supposed to hear? Is there a murmur? Very important. If you do a cardiac auscultation, always on both sides. Okay? There is certain murmurs, especially that you can only hear on the right side, for example. Most people will only listen to the heart on the left side. And that's fine. If you only want the rate, you don't need to listen to both sides. But if you actually do a cardiac auscultation to find out if the heart is normal, you need to listen to both sides. Okay? Okay. What heart sounds can you hear? We have S1, S2, S3, and S4. Okay? You always hear S1 and S2 because S1 marks the beginning of systole, the closure of the AV valves. Okay? S2 marks the beginning of diastole with the closure of the cellular valves. But then you have also S3, which you can often hear in athletic, very fit horses. Okay? It's low pitched, difficult to hear, especially if you're not experienced. But it's important to know because like some people think it's a murmur, but it actually isn't. It's a normal heart sound. And it's associated with passive ventricular filling. Okay? In a very fit athletic horse, the ventricular filling is very rapid. Okay? That causes some turbulence and that makes that sound. Okay? So it is normal in athletic horses. And then S4 is a sound that you can hear very commonly in horses, and it is associated with atrial contraction. Okay? So you should actually, when you listen, you should hear like a blup, dup, and that's the S3, okay? Blup, dup, that's what you hear. Okay? But remember, you will always hear S1 and S2. Okay? There's diseases where you don't hear S4, for example. Okay? So that's why it's important that when you listen to the heart, you have to think, okay, what am I actually hearing? And it takes practice, okay? Like no one expects you to know that, and we're not going to test you to hear if there's a murmur or not, okay? But you need to know, okay? The more often you will hear it, the better you will get at finding these things. Rhythm, okay? After you've now counted your rate, which should hopefully be normal in a routine patient, and you figured out, okay, which heart sounds am I hearing? Now you think about, okay, is the rhythm regular? To know if the rhythm is regular, you need to listen to the heart for longer than just 15 seconds. Okay? So like usually when you count the heart rate, you listen 15 seconds times 4, okay, and you have a heart rate. If you do a cardiac auscultation, it takes a lot longer. It might take anything to 5 minutes, okay, because you want to listen carefully. You don't always hear things immediately. And for the rhythm, it's the same thing, okay? You can, you will have to listen. Now this might be a bit confusing, but you can have a regular rhythm, which is normal. You can have a regular, irregular rhythm, which is not normal. And you can have an irregular rhythm. Okay, so what is that? We're going to get into detail probably tomorrow when we talk about the arrhythmia. We're going to start maybe today still. Regular, irregular means that the irregularity occurs on a regular interval. Does that make sense? So for example, you have like a dropped beat, okay? But that dropped beat happens every 4 beats. Okay, then there's a pause. That's a regular, irregular rhythm. If you have an irregular rhythm, it means it's chaotic. So they come wherever they want to. Fast beats, long beats, anything in between. Okay? But we are going to talk about specific diseases that have these kind of rhythms. Okay? But as I'm saying, it's important to listen long enough so you can say there is an irregularity, first of all, and actually to say it's a regular, irregular occurrence or it's an irregular, irregular occurrence. Okay. Now we're going to talk about murmurs. Okay, what are murmurs? Murmurs are prolonged sounds that you can hear during a stage of the cardiac cycle which is usually quiet. So you here have your loop, dup, And in between the look and the dup, it must be quiet. And then you have obviously your dup look. Okay? In between there should be quiet. There shouldn't be any noise. If you hear a sound there, that's a murmur. How is a murmur generated? Well, it's like a turbulent blood flow. Okay, so that results in vibration of structures, and that makes that sound. It is usually blood that is flowing backwards or in a non-physiologic direction. Okay, remember, in the heart, blood flow is always unidirectional. Okay, blood comes into the heart, goes through its structures, goes out. Okay, other side, right side as well, comes into the heart, goes out. So whenever you have blood that's going back where it came from, it will cause turbulence. Okay, and that will cause a murmur. When we hear a murmur, we need to classify a murmur. Okay, not all murmurs are the same. There's different kinds of murmurs. So we need to talk about time and duration, location and radiation, the intensity, so how loud it is, and the quality. We'll go through these now. To make it a bit more complicated, is we have murmurs that's physiological. Okay, so some murmurs are actually not associated with disease. Okay? And some murmurs are pathological murmurs, so they have underlying structural disease. And it's not always very clear just by listening whether it's a physiological murmur or a pathological murmur. Okay? So just remember, there is murmurs that's normal. Okay. So we said we need to classify, characterize these murmurs if we hear one. Okay, first, most important, time and duration. Are we hearing the murmur between the look and the dup? So between S1 and S2, like that would be your blue line here. Or are we hearing the murmur between the dup and the look, which would be the yellow line, and it would be during diastole. Okay, so you could have a systolic murmur, or you can have a diastolic murmur, which tells you the turbulent blood flow is happening during diastole or it's happening during systole. Okay? You can also have murmurs that's continuous, okay? But that's rare. Most murmurs are either systolic or diastolic murmurs. Okay. Location, where do we hear them? We call that point of maximal intensity, or PMI. Okay? So this is the position on the chest wall where you hear the murmur the loudest. Okay. So wherever the actual underlying problem lies that causes the turbulent blood flow, this is where you will hear the murmur the loudest. Okay. So that's why I said some murmurs you will only hear on the left, or some murmurs you will only hear on the right side of the voice. Or, even more important, you might hear them loudest if you go very basal, or you might hear them loudest at the apex. Okay? Both of them are associated with a valvular region. Okay? I'm going to show you that now. So, valvular regions have certain locations. So, mitral valve area, 5th intercostal space, 10 centimeters below the point of the shoulder, and you don't need to know that for a test, okay? But what you need to know is mitral valve is left, aortic valve is left, pulmonic valve is on the left side, while tricuspid valve is on the right side, okay? Important. So remember, if you don't need to know exactly the intercostal space, although it's fairly easy because it goes 5th, 4th, 3rd intercostal space, and then on the right side is the 4th intercostal space. Okay, so let's say, just to give you some context, you have a murmur that is caused by a turbulent blood flow associated with the mitral valve. Okay, so you will have a disease of the mitral valve, so the murmur will be loudest in the 5th intercostal space on the left side. Okay. So that's why it's important to know where do we hear the murmur loudest. Okay. Now, how do we grade the loudness or the intensity? We have 6 grades, and they have a clear definition. Okay. Grade 1 is a very soft, localized murmur that requires extended auscultation in a quiet environment to detect. Like, if you have never heard a murmur, you will definitely not hear that. Even I will struggle to hear a grade 1. Okay, they're very, very quiet, and they will only be in a very specific location. If you don't have your stethoscope right on that spot, you will not hear it. Luckily, murmurs that's only a grade 1 is usually physiologic. Okay, so it doesn't matter if we hear a grade 1 or 2. Grade 1. A grade 2 can be a pathological murmur already, but often physiological murmurs are very quiet. So anything that's louder than a grade 2 will likely be pathological. Okay? But a grade 2 you can readily hear. Okay? You can put your stethoscope on and you can hear it. It's soft. It's usually softer than S1 and S2. Okay? A grade 3 is also moderately loud and is usually similar in volume to S1 and S2. And grade 4 is fairly loud and it radiates wildly, which means no matter where you put your stethoscope on the heart, you will hear it immediately. Okay? And then you can work around and see, okay, this is where it is loud, but you will hear it immediately. A grade 5 has a palpable thrill. So now you listen, you hear your murmur, and you put your hand on the chest at the level of where the heart is. So if you think here, right, behind the elbow, you put your hand there and you will feel vibration. Okay? In addition to obviously the murmur. That's a grade 5 murmur. And then a grade 6 is a very loud murmur that you could actually hear without your stethoscope. If you just put the stethoscope like a few centimeters away from the chest wall, you will already hear it. Okay, so that's what the definition of a grade 6 murmur is. Okay, any disease that causes a murmur can have anything from a grade 1 to a grade 6. It depends. Not always, but it can depend on the severity of the disease, it can depend on other things, okay? So you can have the same disease in different horses, and one horse has a grade 2 murmur, the next horse has a grade 4 murmur, and so on. So the murmur doesn't necessarily tell you anything about the severity, but it is important for progression, okay? So usually if you have, let's say, you detect a horse that has a grade 3 murmur, and 3 years down the line, you keep on monitoring that horse, the murmur becomes louder, it's likely that the disease has progressed. That's why grades are important. Okay. Quality, we also describe the quality as musical, soft, coarse, harsh, flowing, vibrant, sweet. There's all sorts of different words that we use because you can actually hear differences. And the more experienced you are, the more you can say this murmur is that disease. Okay, this murmur is that disease. Okay, very, very typical. We also describe whether we hear the murmur evenly throughout systole, that would be band-shaped. Okay, or if the murmur becomes louder, that would be crescendo, or if the murmur becomes quieter, that would be a crescendo murmur. Okay? Alright. So how do we correctly describe a murmur? If we have one, you will say, for example now, it is a right-sided location, polysystolic timing, band-shaped, that's not a quality, and coarse murmur, it's also quality, grade, loudiness, grade 4 or 6, with a point of maximal intensity over the tricuspid valve, for example. This is where we hear it the loudest. Okay, so that's also location. Or we will say left-sided, polodiastolic, descrescendo, blowing murmur, grade 3 out of 6, with a point of maximal intensity over the aortic valve. Okay, so this is how you correctly describe a murmur. Okay, what do you do now? Okay, I'm going to talk about murmurs now in more detail. So now you've heard a murmur. Now you have to ask yourself, is this physiologic? If it is, then you don't need to do anything about it. If it is pathologic, we obviously need to find out what causes that murmur. So we need to do further examination. If you're not sure, you can always do further examinations. Because the nice thing about cardiology is like none of our diagnostic procedures are invasive. Okay? So you might as well do it. It costs money, obviously, but you will, if in doubt, rather do the examination. Okay. Now, important, because I don't know why, but like people seem to get that wrong. We have our two main diagnostic tests to use in cardiology is echocardiography and ECG. Okay, echocardiography is the ultrasound of the heart. Okay, we do that when we suspect a structural cardiac disease that causes a murmur. So whenever you hear a murmur, we do echocardiography. Okay, right. For some reason, like I know from the last few years, like people mix up echocardiography and ECG. And ECG, same as in small animals, is like you're checking your heart rhythm. Okay, ECG does not do anything else other than looking at cardiac rhythm. So when do you do an ECG? When you have an arrhythmia. Okay, when you hear an abnormal rhythm, you do an ECG. If you hear a murmur, you do echocardiography. Okay, remember that. Very simple. Okay, now, we said cardiac murmurs can be physiological or they can be pathological. So they can be associated with cardiac abnormalities. Physiological murmurs are usually associated either with very fast ejection or very fast filling. And that can be normal. It's just like fast filling, the blood is rushing, it's causing some turbulence, it's causing a murmur. Okay? And as I said, you can't always, just by listening, tell whether it's physiological or not. Pathological murmurs, and that's now very important, okay? And it makes it much easier in horses than in small animals, okay? So, as I said, they are associated with abnormal blood flow, plus minus cardiac abnormalities. Sometimes you don't actually find a cardiac abnormality. But murmurs in horses are almost always associated with valvular regurgitation. So a leaking valve, okay? Valve that should be shut, and there's a little bit of a leak, so blood can flow backwards, okay? Valvular regurgitation, most common cause of murmurs in horses. Stenosis that you see in small animals basically don't exist in horses, okay? They just don't have them. There is case reports of horses with stenosis, but it's very rare, okay? And then you have abnormal communication, and this is, for example, a ventricular septal defect, or an atrial septal defect, where there's actually a hole in the septum. Blood can flow from the right side to the left side. That's called an abnormal communication that we see also, not as commonly as valvular regurgitation, but we see that, and that's also causing a murmur. Okay? Now, we said functional murmurs, you can, and you don't need to know this table, okay? It's just for you to understand that a functional murmur is different than a pathological murmur, but it's not always clear, okay? So you can have on the left side, systole is often associated with aortic ejection. If you hear one at diastole, it's often associated with diastolic filling. And then you can have presystolic murmurs as well. On the right side, you can have in diastole and presystolic murmurs. You don't, as I said, you don't need to know this table. This is just for your information. This is important, okay? Usually they are localized, so you can only hear them in one spot. They are short duration. They are almost never like the whole of systole or the whole of diastole. You might hear them at the very beginning of systole or at the very end of diastole. Okay, so short duration, and they're very rarely higher than a grade 3 in loudiness. Okay, so that's important. That is just for your information. Now, pathological murmurs, and this is very important, so this you need to know, okay? If you hear, you said like the murmurs are very much associated with certain diseases, depending on where you hear the murmur, when you hear the murmur, the timing. So if you have a horse and you hear a murmur on the left side in systole, it is 99% associated with mitral regurgitation. Okay? And typically the characteristic is that you have the point of maximal intensity over the mitral valve, because obviously you now have a mitral valve that's leaking. It is typically holosystolic, and it's typically fan-shaped or crescendo. The grade depends on the individual case. Okay, there can be anything from a grade 2 to a grade 6, depending on how severe the mitral regurgitation is. Okay, but that's this we need to know: location and timing. If you have a murmur on the left side in diastole, it is associated with aortic regurgitation. Okay, now your aortic valve is leaking. Okay, the point of maximal intensity over the aortic valve. It is full of diastolic murmur, so you hear it throughout diastole. It is usually this crescendo murmur and has like a musical character to it. Very important here, I said in mitral regurgitation, the higher the grade, the more severe the disease. In aortic regurgitation, it's not the case. It's often not associated with the severity of the disease. On the right side, if you hear a murmur in systole, it is usually associated with tricuspid regurgitation, and with the point of maximal intensity over the tricuspid valve, it's holodiastolic and fan-shaped, but a ventricular septal defect, which is the hole in the septum, right, where blood can flow now from the left side to the right side. You also hear a right systolic murmur. Same, you have the point of maximal intensity over the tricuspid valve. It's also holosystolic. The quality of the murmur or the characteristic is usually a little bit different. It's like coarse and harsh. And same thing here, the intensity does not reflect the severity of the disease. So based on the murmur on the right side, in systole we can't really differentiate between tricuspid and ventricular septal defect. But based on the murmurs on the left side, we can pretty much already, just by knowing what type of murmur we have, say the horse either has mitral regurgitation and aortic regurgitation. Okay, so these four diseases are your most common and most important cardiac diseases that cause murmurs. Okay? And there's other diseases as well, but this is the ones that you actually need to know. Okay? Because that's common in horses. That's what we see. That's what we see in normal horses that don't have any other problems. Okay. As I said, if you hear a murmur, your next step would be echocardiography. And here is a list of indications when we perform echocardiography. Okay? Not all murmurs need in a healthy horse. Okay? We're always talking about an otherwise healthy horse that doesn't have any clinical signs. This is important for you to know. Okay? Because this is like what we experts have agreed on when we do echocardiography, because we're suspecting a structural cardiac disease. Okay? If you hear murmurs that's very quiet, you see here like it's grade 3, grade 4. So, and if you hear quiet murmurs, grade 1 or grade 2, we usually don't do an echocardiogram because they're usually associated either with a physiological murmur, or the disease is so mild that it's not going to make any difference. Okay? So remember this slide here. I mean, I'm going to give you that slide. Also, you also have that in your notes. If you hear murmurs that become louder on serial examination, those must also be examined. That if you have murmurs that you think could be associated with a ventricular septal defect, that's a congenital defect, then you must also do an echocardiogram. Usually, like, you detect them in the first veterinary exam of a young horse because they're born with that defect. So the murmurs will have been there since birth. Okay? If you have continuous or combined systolic diastolic murmurs, or if you have a murmur during a pre-purchase examination. So any murmur that you hear on a pre-purchase examination, you must recommend echocardiography, and that's just for insurance purposes. Okay? All right. So remember that, yeah? Okay. 5 is that enough? Okay. Right, just to clarify for everyone, I was just asked whether you need to be able to do grading of murmurs, and the answer is absolutely not. So we're not going to ask you to listen to a murmur and then say what you're hearing there. I mean, you have no ways of practicing that. So, but what you need to know, that's why I was so adamant with that table, is the location and the timing. Okay, so if I say to you, you have a course where you hear a left-sided murmur insistently, you need to know that that's mitral regurgitation. Okay, so that's this here, these 3 columns here, those you need to know. Okay, you need to know that you can grade this, that you can grade murmurs, but you don't need to know how to do that. Okay, you need to know what's the definitions of the grade of the different grades, but I'm not going to ask you to like, here's a murmur for you, now tell me what grade it is. Okay, I mean like, not all residents don't always get that wrong, and we all sometimes don't agree. Like sometimes someone says, like, I think it's a grade 3, and someone else says, no, I think it's a grade 2. So that's very subjective. So like, it's obviously not something that we expect you to know. But this you need to know, okay? And you don't need to know the characteristics either, because like the characteristics can change, okay? Like one horse will have this, another horse will have that. It's not always clear, okay? But as I said, this is always the same, okay? This does not change. So you need to know that. Okay, and you do need to know this, okay? You do need to know, like when you go out in the field and you hear a murmur, and then hopefully you do grade it correctly, and that you then know, must I send this horse for echocardiogram or not? Okay, so know this slide here. Okay, so we're talking about, you have now a horse, routine patient, no abnormalities other than a cardiac auscultation where you heard the murmur. We're going to do an echocardiogram to find out whether there is any structural cardiac disease. Okay. Now you might ask, hey, I said that you already know, based on the murmur, what disease the horse has, so why must I do further examinations? Okay. So what you do not know is how severe is the disease and what's the specific cause. You know it's caused, so let's say, go back to our example, you have a left-sided systolic murmur, so you know that's most likely mitral regurgitation. So you know the mitral valve is leaking, but you don't know why the mitral valve is leaking. Okay? So you don't know what's wrong with the mitral valve. You just know that it's leaking, but you don't know why. So we don't know the specific cause. Okay, so that's why we need to do an echocardiogram. And we also don't know how severe is the leak. Has it caused any other abnormalities? We're going to get to that when we go through the different diseases. Okay, so we still need to answer, because like now the owner is going to ask us, is like, what am I going to do with my horse if it has a cardiac disease, okay? So is it going to impair athletic performance? We can't tell that just by listening to the murmur. Is it suitable for the intended use? Is there any risk to rider safety? Has it maybe reduced value? Can it not be sold if it's a pre-purchase examination? Is this disease likely going to progress or not? Maybe I need to sedate my horse, or like a horse needs to have a surgery and has general anesthesia. Is that going to affect that, or does it make the risk higher? Is there any change in quality of life? Or can I treat the horse now? So all of these questions we can't answer by just listening to the heart. Okay, so we need to do further examinations to get to the bottom of why is the mitral valve, for example, now leaking. Okay, so we said murmur, echocardiography. Okay, remember that. We're doing an ultrasound to look at the heart and to see if the structures of the heart are all normal. To do that, you need to have specialist training. You're now ultrasounding a moving organ, so it's not as easy as it is. You need quite advanced ultrasound machines for that, so not every ultrasound machine can do that. You also need to have a specific probe, okay? So you'll see for musculoskeletal, you usually use linear probes. If you do abdominal ultrasounds, we use these curved linear probes. And for cardiac ultrasound, we need to use these phased array probes, which you usually in like a normal setting don't have. Okay, so you need to have quite advanced machinery for that. Okay. Murmur. So we're still talking about clinical assessment. Okay. So remember, now you heard a murmur. You have your indications for when you need to do further assessment, and the further assessment is you do an echocardiogram. Okay? Now we're doing a different scenario. Now we are having an arrhythmia that we heard on auscultation. Okay, what do you do then? Okay? So now you're listening to a heart, still a routine patient, doesn't have any clinical signs. Maybe it has poor performance, but otherwise clinical examination is normal. Now, as I said in the beginning, we need to say, is the arrhythmia regular? Is it regular, irregular, or is it regular, irregular? Okay? Same as what the murmurs. Some arrhythmias are physiological. Okay, so they are normal, like they're not associated with any disease. If in doubt, we always do further assessment. Okay? So, important now. This time, I don't want anyone to answer in the test. When I ask about an arrhythmia, what test you do, that anyone says echocardiography. Okay, you do an ECG. Okay, same by the other way around. If I ask for someone what you do in a murmur, you're going to say echocardiography and not ECG. Okay, I've had that too many times. I don't know why it is. So it's very simple. Okay, if you hear an irregular heartbeat, you're going to do an ECG because you want to know what type of arrhythmia is that. You just know now by listening it's irregular, there's an arrhythmia, but you don't know what type of arrhythmia it is. Okay, you might have to do then further examinations, like you might have to do an echocardiogram, you might have to do blood work, something like that's called cardiac troponin. We're going to talk about that a little bit later. But the first thing that you do is you do an ECG, okay, electrocardiogram, not echocardiogram. All right. So I said arrhythmia, so it's the same as with the murmurs, okay? So we had the physiological murmurs, we had the pathological murmurs. Now we have arrhythmias. We have physiological arrhythmias and we have pathological arrhythmias. So you listen to the heart, the horse is standing still at rest, and you hear this arrhythmia. Okay. This is a list of arrhythmias that's physiological. Remember that list, okay? This is the type of arrhythmias that you can have. And important, they are only present at rest and the horse is relaxed. Okay? If you stress this horse or you exercise it and you listen to the heart again, it should be gone. Okay? It shouldn't be, then it should be regular, normal cardiac auscultation. If you have a pathological arrhythmia, we're going to go through these arrhythmias, they will obviously stay. They will not go away. Okay? So remember that if in doubt, if you're not sure, you just do an ECG and you know exactly what, then you can say, it's a second degree arrhythmia. No, it's an atrial premature complex. You will be able to tell on the ECG immediately. By listening to the heart, you will not be able to tell. Okay? But it is a nice little test to do if you're not sure. You exercise the horse, if the rhythm becomes completely normal, then it's very, very likely physiological and you don't have to do anything. Okay? Alright. Indications for ECG. So we had this long list of indications when we do an echocardiogram with all these different kind of murmurs. With the arrhythmias, it's much easier. Okay, any arrhythmia at rest that you can't tell 100% that it's physiological, you do an ECG. It's not invasive, it's simple, and you know immediately what's going on. Okay? And very important now, this is what makes the arrhythmias a bit more complicated. You can't hear all arrhythmias at rest. Okay? Because some arrhythmias are only present during exercise. So the heart will be normal at rest. But the moment you're exercising the horse, there's more strain on the heart. The horse might have arrhythmias. And you can obviously not hear that. Okay? So these are commonly horses that have poor performance or they have like a history of collapse. Like they have that, poor performance, you listen to the heart, everything sounds fine. But they might have an arrhythmia still that is only present during exercise. Okay? So we need to still do further examinations. to find out what might be going on. Exactly the same as with the echocardiogram. Why do we need to do ECGs? Well, we don't know what type of arrhythmia it is, we said it, and we don't know what is the underlying disease. So like now, we're going to go through the different arrhythmias and we're going to talk about what causes them. And some arrhythmias are caused by structural underlying cardiac disease. So you might have a horse that has aortic regurgitation, for example, okay, so a leaking aortic valve. And secondary to that, you might have an arrhythmia. So the horse might have both, okay. In that case, if you hear the murmur, that's what you usually hear first. You do your echocardiogram. Based on the echocardiogram, you will say it's likely that this horse might also have an arrhythmia, and then you do an ECG, okay. So if you suspect or if you've diagnosed an underlying disease, you might also do an ECG afterwards. Okay? The questions are exactly the same to answer as what we had with the murmurs. Okay? Okay. How can we do an ECG? It's actually also very simple and it's quite nice. We have this like pocket-sized ECG device. It literally is like the size of a mobile phone. And you can use that either for a resting ECG, so you can put that on or standing and you just get a short snapshot of what's happening, or you can do a 24-hour recording. Okay, as I said, not all arrhythmias are present all the time, so we can see over a 24-hour period how many arrhythmias does that horse have. These devices have a small SD card in it, and it records the ECG, so afterwards you import your ECG to the software, and you can go through all the ECG, 24-hour ECG, to see if there's anything abnormal happening. And we can also use it for exercise, so you can see here this horse there with the rider on it. The horse actually is wearing an ECG, so you can also do exercise ECGs at the same time, and you can see that live, okay? So it transmits via Bluetooth to your computer or even to your mobile phone. It's quite advanced now, and you can see it live, and you can afterwards obviously go and analyze it as well. This is what it looks like with the ECG. You can't even see it. You have these like specific singles here where the cables and the device is placed under, so that the horse can actually continue with its normal routine and just wearing the ECG. Or if you're riding, you can see here electrodes sit under these patches here, and like the little device is here attached to the saddle, so the rider can ride while the ECG is on. You can see here exercise test either on the lunge or rhythm or even on the treadmill, okay, as you can see here. So you can have the horse cantering on the treadmill. When you do an exercise test and you want to like trigger an arrhythmia to be sure if there's an arrhythmia or not, you need to have the exercise be at least equal or higher than a normal horse's activity. So there's no point if you have like a race horse, you want to know if that horse has any arrhythmias while it's racing, if you're lunging it around a little bit, okay? That's not going to trigger anything. And when you do an exercise test, you should always include the ECG, obviously, not just do the exercise. Okay, when we do exercise tests, that's mostly in horses with poor performance, or where we expect an arrhythmia, or we are not sure whether this horse has an arrhythmia. Then we do this exercise test, and we look at how high does the heart rate go, and what is the rhythm, okay? And also what happens during recovery. So you get a graph like this, okay? This is now just a heart rate graph. So here's the heart rate. This is the time. So you can see here, here's the horse is walking, okay? Heart rates of, see it's too small, but doesn't matter. It's like, let's say 40 to 50. Then the horse starts trotting, so you can see the heart rate's coming up. Then we have like cantering, and this is like now on a treadmill, so we're making the treadmill faster and faster and faster, so the heart rate goes up to a maximum of 220. Then we stop the treadmill, obviously we're stopping the horse at the same time, and so it doesn't fall, and we're looking at how quickly does the heart rate come down, so that's the recovery. If we see arrhythmias now, we will have little spikes like this, for example, okay? This is an arrhythmia. It occurs, just one single abnormal beat, okay? So that's what we're looking at. So we're looking at the heart rate, and then we're obviously looking at the actual ECG, okay? So this is what it will look like, an overview, and we can go through this and see, you obviously don't need to know how to analyze ECGs, it's just for you to understand what we are doing, and we will ask, are there any arrhythmias occurring? If there are any arrhythmias, what type of arrhythmias is it, and how many are there? And then we will say, is this dangerous or not? Like some of these arrhythmias are dangerous, even if it's just one single abnormal beat, and some of them will cause poor performance. Okay. All right, so now we talked about all the assessment. Okay, I hope you will all understand now what we need to do in terms of cardiac auscultation, murmurs, arrhythmias, what's the next step that we do. Okay, now we're going to do some cases so you actually see how we do this. All of these cases that we do now is routine patients. Okay? All right. So this is a thoroughbred filly, 6 years old, and clinical examination completely normal, but we found a cardiac murmur incidentally during a routine examination. Horse is normal performance and is used as a dressage horse. The murmur that we found is a grade 4 out of 6 left-sided polysystolic murmur, and we found it in fan-shaped. Okay, so we saw it, we heard it on the left side loudest. Okay, it was between S1 and S2, so it was a look, psh, okay, this is what it sounds like. Okay, if you hear a murmur like that. All right. Okay, what's the cause of this murmur? Anyone? Loud. Very good. Okay, so already we know mitral valve regurgitation, very, very commonly. Okay, going back to this table that I showed you. Okay, we suspect this horse has mitral regurgitation. What are we going to do next? What are we doing? Nothing. Echocardiogram. Okay, good. So we're doing an ultrasound. We want to now know. Remember this slide, okay? Indications for echocardiography. A grade 3 to 6 out of 6 left-sided systolic murmur that is consistent with mitral regurgitation. Okay, we said this is a grade 4, so that falls into that category. So we must recommend send this horse for an echocardiogram. Okay. Why do we do that? Because now we need to know what is the specific cause of the mitral regurgitation and how severe is the mitral regurgitation to be able to answer all of these questions. You saw the slide before. Okay, so what are causes for mitral regurgitation? So I said to you, like now we need to know what's the cause, right? So here's a list of causes that you should know. So you can have degenerative valve thickening, which is like a kind of fibrosis that we often see in older horses. We can see have as a cause non-septic valvulitis, which we think, but it's not 100% sure, it's immune-mediated or secondary to a viral disease. It's like some thickening of the very fine tissue of those valves that cause them to leak. Right? They don't close perfectly anymore, which we often see in younger horses. Infective endocarditis is rare in horses, okay? We don't see that, and we don't see that in a routine patient, usually because they have like fever, they're systemically sick, okay? So we don't expect that in a horse like that. Mitral valve prolapse is something that we see in horses sometimes where just the mitral valve like sort of prolapses into the left atrium, and that causes the mitral valve to leak. And then we can also have mitral regurgitation secondary to other diseases. Now think like there's like a disease that makes the left ventricle bigger, okay, so like it dilates, So it sort of like stretches the mitral valve, okay? You have like your leaflets that come together. Now your heart is bigger than normal, so it stretches it open, okay? So it makes like a little gap and the blood can flow backwards, okay? So that is, for example, secondary to valve annulus or ventricular dilation with other diseases, okay? And then you can have mitral valve dysplasia. So that's like the mitral valve has an anatomic abnormality, okay? That usually is, the horses are usually born with it, okay? So these causes we don't know just by listening to the heart, okay? We don't know, does the horse have problems? Does the horse have fibrosis? And the prognoses for these kind of causes are different. Okay? That's why we need to know what is the cause. Okay? Now, we also said we want to know what is the severity. Okay, so how do we say how severe is the mitral regurgitation? Okay, so normally, you know, in systole, the mitral valve, here's the mitral valve, okay, this is the left atrium, this is the left ventricle, this is the aorta. So it's just the left side of the heart that's pictured here. And you see that the mitral valve here in systole should be completely closed, okay? And then now the left ventricle contracts. All the blood should go out into the aorta. Okay? So now when you have leaking mitral valve, you have mitral regurgitation, some of that blood that's supposed to go out into the aorta is now flowing back into the left atrium. So what does that cause? Like that left atrium has only like a certain size. Now we're not doing systole, there's some blood that's coming back from the periphery, okay, coming back from the periphery into the left atrium, is stored there and waiting for the mitral valve to open so it can flow into the left ventricle. But now at the same time, there's like blood that's coming back into the left atrium as well. So you get volume overload, okay, so there's more volume in that left atrium, which causes a higher pressure in that chamber. And for a long time, usually horses tolerate it well. Okay, that left atrium is like, no problem, I'm happy with that, I can tolerate it. But if it becomes too high the pressure, that left atrium will start to become bigger. Okay, it will become bigger, slowly, bigger, bigger, bigger. We obviously grade everything as mild, moderate, severe. So same thing, we will say, okay, we have a horse with mitral regurgitation. Does it have a changed left atrium? Or then there's no abnormalities, that's good. Or does it have a mildly enlarged left atrium, or moderately or severely enlarged left atrium? Okay. That we also don't know by just listening to the heart. We need to do an echocardiogram for that. Okay. This is the same thing basically, what I just told you about if you have, we call that chronic compensated mitral regurgitation. So mitral regurgitation has been there for a while, it's compensated, it's not causing any issues, but there is chronic volume overload, okay? So always the left atrium is getting more blood than it should, okay? So here is an echocardiogram, and you see here the left atrium, this one. So in an echocardiogram of a horse, the heart is always like kind of upside down, okay? So here is obviously the top of the heart. So this is the left atrium, this is the mitral valve, and this here, where you can't see the whole structure, is the left ventricle. It's also something that you, sorry, there's like a video playing with that valve, so ignore the cursor there. Okay, so you can never, the heart of the horse is so big that you can never image the whole heart. Okay, on an echocardiogram. You have to like go at different angles and look at all the different structures separately. Okay, so here we can see how big is that left atrium. And then this is another view, this is like a short, what we call a short axis view. You don't need to know, obviously, what I'm telling you there now. It's just for your understanding of that, is how we assess the left atrium. This is the left atrium in short axis, which means we're looking at it in ultrasound like in transverse, and then we're cutting through the heart like this, so you can see the aorta here, and this is the left atrium. As I said, you don't need to understand this. The important thing is that you know we are looking for a left atrial enlargement. Is it bigger than normal? Go back. Because now it becomes complicated, and I said to you, we're doing the first thing that we're doing is we're looking at the severity and the cause. Okay, now we found, okay, in this case, for example, the left atrium is actually fairly enlarged. Okay, so probably moderate at least here in this image. If you have moderate enlargement of the left atrium, secondary you can get arrhythmias. Okay, so now this force specifically is prone to develop atrial arrhythmias. So it's a specific type of arrhythmia, also atrial fibrillation. If it would now go more severe, would progress further, you would get like left ventricular enlargement, pulmonary hypertension, and it can go into heart failure. But as I said, this is very rare. Okay? This we see it more common. Okay? So this is what we need to know. This is how we say how severe is the disease, and we're obviously looking at the mitral valve itself to be able to say this is the cause, this is why it's leaking. Okay. So when we talked about this, we do the comprehensive echocardiogram. We did that. Now we know what's the etiology, what is the cause. We know what's the severity. Now, do we need to do anything else, like an ECG, to say maybe this horse also has arrhythmias? If you have a horse, if we grade the mitral regurgitation as moderate to severe, then yes, we do an ECG. Okay, we do a 24-hour ECG and an exercise ECG, we check if there is any atrial arrhythmias as well. But the first thing for murmurs is you do an echocardiogram. Okay? Alright. So, just that we are talking about the case that we just had. Okay, remember we had the 6-year-old grade fully used for dressage where we incidentally found a grade 4 out of 6 systolic murmur on the left where we suspect mitral regurgitation. Now that's exactly what we're doing now. Okay, so this is now an echocardiogram. Just you see it's moving. We see this is the left atrium here, mitral valve. This is the left ventricle. This is the right side of the heart, very small. Okay, so we're looking at the size of the heart, and we're obviously not just subjectively saying, oh, that looks maybe big or not. Now we obviously do measurements, like we are more specific, we do objective evaluations. So we measure how big is it, or how large is the diameter, and we measure like the area here, all things that you don't need to know. Okay, it's just for your understanding. And we have reference ranges, and so we can actually tell is it really enlarged or not. Okay, so in this case, it was, if you look at the numbers here, it was moderately enlarged. And then we also have this view that I just showed you where we're looking at the left atrium here. Okay, so we also do measurements in that view, and we say, yes, it is enlarged. And then we actually look at, okay, is the mitral valve really leaking? We can actually show that on an ultrasound, which is quite nice. So if you look at this image here, now this is the mitral valve. We put that color flow Doppler, we call that on, which shows blood flow either towards the probe or away from the probe. Okay, so if it's coming towards the probe, the blood flow, the color goes red. If it goes away, it's blue. All things that you don't need to understand, you just need to understand the image. When it's turbulent, it becomes green. Okay, so now you see that green color here. Right? Now, and you see the green color, you actually see when the mitral valve is closed. Okay, so when there shouldn't be any blood flow there. So we can see that there's blood flowing backwards. Okay? And then we look at the mitral valve itself to see if it's abnormal, and we thought here, okay, it has a little bit of thickening, so that's suggestive of non-septic valvulitis because we have a young horse. Okay? It's a 6-year-old horse. We said if there's a little bit of thickening, but nothing else, it's likely non-septic valvulitis. So now we've diagnosed this horse quite nicely. Okay, we have a moderate mitral regurgitation because we have enlargement of the left atrium, and we have as a cause a non-septic valvulitis. We did say if we have moderate or severe mitral regurgitation, we need to do an ECG to check if there's any arrhythmias, and we did that, and there was no arrhythmias detected in this specific case, which is good. Right? So we said we're doing all of this to give a prognosis and answer all these questions that the owners might have, and what can we do with this horse. So Let's jump to the prognosis first. In this case, we are saying mitral regurgitation is unlikely to affect performance unless it's relatively severe, and if it's not so relatively severe, it's moderate, okay? But disease progression is possible. So this disease at this stage is probably not affecting the horse at all. It's a dressage horse, so they can usually perform perfectly fine with this disease. There's no risk with this disease either. But it can progress. So what we need to do is we need to follow this case and be able to change our prognosis in case the disease progresses as well. Okay? So we do yearly examinations in the beginning, and if it's mild, we do every other year, so every second year. If it's moderate to severe, we at least do annual re-examinations where we just do an echocardiogram and we check if anything has changed. Has this left atrium become bigger or not? Okay. We talked about treatment at the very beginning. We can't do valve replacements. We can't make this valve stop leaking. Okay, so it will continue to leak. There's nothing that we can do about it other than monitoring this horse and tell the owner this is now the time where you shouldn't ride the horse anymore, or maybe the horse has now developed an arrhythmia in addition and it's actually causing poor performance. Okay. In this case specifically, we said it's unlikely to affect performance, the horse is safe to ride, but there is an increased risk of further down the line developing atrial fibrillation as an atrial arrhythmia, so that there is definitely a chance that it will do that further down the line. I followed this case for quite a while, so I think I saw this case first in 2015, and then we followed it, as you can see here. And it had a mild progression in 2020, so 5 years later, where we found that the left atrium was a little bit bigger than it was before. And I saw it last in 2022, and the horse is still stable, there's no changes. So you can see like they tolerate these diseases very well. Okay, so it doesn't actually make a difference. If this horse now was a race horse, okay, it would be different. We would probably say, don't invest in this horse. This is likely at some stage to cause poor performance. Okay? So really it depends, as what I said to you in the very beginning, you need to know what age is the horse, what is the horse used for, what is the intended use if it's a young horse, okay? Because it will change. In this case, it didn't change because it's fine, like if it's a large horse, that should be okay. But if it's a different type of horse, it might be a different prognosis. Okay? That's not things that we will ask you in the test, okay, in terms of like, because it's very individually case-based what type of prognosis you give the horse, okay? All right. Any questions on this case? Okay, good. We do the next case. All right. This is a 9-year-old quarter horse, mare, used for endurance. And actually, this horse had a murmur already present for 3 years, but no one ever looked at it, which we shouldn't do. We should look at it if we hear a murmur. Clinical examination, normal and no poor performance. Classic kind of scenario where you hear a murmur, but the horse is perfectly fine, sort of like a kind of like general idea is, well, that's not significant, okay? But we know we have our list of recommendations when we should do an echocardiogram and when we should do further examinations. And in this case, the murmur was a grade 4 out of 6, yes, crescendo murmur, holodiastolic, okay, so now remember, left side in diastole, grade 4 out of 6, so it would sound like look, dup, shh, look, dup, shh. Okay, this is what the murmur would sound like. And what do you think is the most likely cause of this murmur? Left side, diastolic, murmur, what is it? Yes, aortic regurgitation. Very good. Okay, so you're already passing your exam. So, remember, left side diastole is aortic regurgitation. Most likely aortic regurgitation. What do we do with this case? Go on, echocardiogram. Now here more. Okay. We do an echocardiogram. And there we have that slide again, okay, that you need to know. Okay, grade 3, 2, 6 out of 6 left-sided murmurs in diastole where we think it's aortic regurgitation must have an echocardiogram performed. Okay. Why? It's like we're repeating ourselves, as you can see here, because we don't know what is the specific cause. Oh, sorry, this should be aortic regurgitation. Sorry, my mistake. This is the obviously suspected cause of aortic regurgitation, and we don't know how severe it is. Okay. Causes of aortic regurgitation becomes very simple because it's pretty much the same as mitral regurgitation, so all the valvular regurgitations can have the same causes. It might affect only one valve, sometimes you have two valves affected. Same thing, okay, so degenerative valve thickening in older horses, non-septic valvulitis in younger horses. Endocarditis, as we said, is rare and usually associated with fever. Same as with mitral valve prolapse, you can have aortic valve prolapse, you can have congenital malformations, and in some horses that also have a ventricular septal defect, you also have aortic regurgitation. So you can also have two diseases at the same time. Okay. Okay, severity. So we need to look at the specific cause. Next thing, we need to look at severity. Very simple. Same as with mitral regurgitation. What happens? Okay, usually during now, this is like a diastolic murmur. What happens in diastole? The mitral valve is open. Blood flows usually from the left atrium into the left ventricle, and the aortic valve should be closed. Okay? Now, if the aortic valve is leaking, there's blood coming back from the aorta into the left ventricle. Same, now it's just a different chamber. You have volume overload in the left ventricle. The pressure becomes higher to an extent where the left ventricle becomes larger. Okay? Same principle. Okay? So now you saw the slide before with the mitral regurgitation. Now we have chronic compensated aortic regurgitation. We have chronic volume overload in the left ventricle, causes dilation of the left ventricle, becomes bigger. Now that causes ventricular arrhythmias. Okay, think about it like atrial arrhythmias means the arrhythmia comes from the atrium. Ventricular arrhythmia means the arrhythmia originates in the ventricle. So if you have an enlarged left ventricle, you have ventricular arrhythmias. Very logical, as you can see. It's not so difficult, okay? So, and that happens. Now we also said like if the left ventricle becomes bigger and bigger, it stretches the annulus, so it can stretch the mitral valve. Now secondary you can have mitral regurgitation. Then you have the same situation if you have only mitral regurgitation. The left atrium becomes also bigger, so now you can have atrial and ventricular arrhythmias. So this is the things that can happen if a horse has aortic regurgitation. They might not be there at all, or it might be completely normal. But if it progresses, this is what's happening. Okay? Okay. Another thing that's specifically important with aortic regurgitation is blood pressure. So when you do your clinical examination and you feel your pulse over the facial artery, you feel what we call a hyperkinetic pulse. It's just like bounding, it's very prominent, like you can feel it, and it's like almost going like poof, 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 okay? So you can feel it very nicely. And that's very typical with moderate to severe aortic regurgitation, and it's caused by that volume overload in the left ventricle. Think about it. Now, the left ventricle has much more blood in it when it's bigger than normal. So let's say in a normal course, the amount of blood, maximum amount of blood in the left ventricle is about a liter, maybe 1.2 liters. If it's properly, moderately to severely enlarged, it can go to 2 liters. Now, with every contraction of the left ventricle, these 2 liters need to be pumped out. Okay, and the heart can manage that. Okay, but now, like, there's a much bigger volume coming out, which increases your blood pressure. Okay, makes sense, right? Like, there's all this blood coming out. Okay, pulse pressure that we're actually feeling. Okay, we're not feeling systolic or diastolic pressure. We're feeling pulse pressure when we do a physical examination. Is systolic minus diastolic pressure. And typically, in an aortic regurgitation, because we have this volume overload, we get higher systolic pressure and lower diastolic pressure, so which makes your your pulse pressure higher, okay, because the difference is bigger. Okay? Usually you get to like more than 60 millis of mercury, where it should usually be like 40. And now normal blood pressure in horses is the same as in people, 120 to 80. So which gets you to a pulse pressure of 40. And with aortic regurgitation, you usually get fairly high pulse pressures. As I said, only with moderate to severe aortic regurgitation, we actually have volume overload. So it's a nice thing that if you actually have a clinical examination, you hear your murmur, you think, okay, it's left side diastolic, it's aortic regurgitation, now you feel the pulse, and you feel this bounding pulse, you already know that this is likely moderate to severe at least. Okay? Doesn't mean that you shouldn't do an echocardiogram, you still need to do that. Okay. So, what's our recommendation? We need to do an echocardiogram to determine the most likely etiology, to assess severity, and remember, for aortic regurgitation, I said that in the beginning, that grade of the murmurs or the loudiness is not associated with the severity. So you can have a fairly quiet murmur, like a grade 2, which might be severe aortic regurgitation. Okay? So you can't associate it with them. Okay. Now, again, don't get confused. We're still first doing an echocardiogram, but same as with mitral regurgitation, once we said it is moderate to severe, we also need to do an ECG. Because we said, as a consequence, the horse might also have arrhythmias. That's not primary, it's secondary arrhythmia. Okay? So we need to see if the horse has ventricular arrhythmias, and it's important because ventricular arrhythmias can cause collapse and sudden death. Okay? So that's an important one with aortic regurgitation to assess. Okay, this is the case that we talked about. Okay, so now we have on the screen here the left ventricle. This is the mitral valve. This is part of the left atrium. This is the right side of the heart. We can't see the aortic valve here because what we want to know is the left ventricle bigger than normal? And I can tell you already it is. So the volume here was 1,520 mils. And it should be less than 1,200, so it's almost 2 liters. So we can do measurements to do that. We can also, so now we're looking at a view where we can actually see the aortic valve. It's this one. Okay. This is the aorta here. And you can almost, like, if you look carefully, you can almost see the gap there. You know, like these two leaflets, they don't really come together. And it has, like, very thickened, like the tips are properly thickened. Okay? We can do something, it's called an M-mode, where we can look at what the ventricle does over time, but we can also measure here the diameter. As I said, you don't need to know these kind of views. Just to give you an idea of what we actually do, we could see the diameter was 14.2 centimeters, and it should be less than 12.5. Okay, we look at what the color Doppler. You see here the green color. Okay. Now remember, like the regurgitation is flowing from the aorta back into the left ventricle. So you see that green color flowing, shows the flow back into the left ventricle. So in this case, we also graded this as moderate aortic regurgitation. The horse was only 9 years old, but, and this is now experience, okay, this thickening here is not so typical with just valvulitis. So I I thought there was some degenerative abnormality on that valve, but it doesn't actually make a huge difference. But if it's not like a more severe abnormality, like endocarditis, for example, but I thought, although the horse was only 9, this looks more like degenerative. Okay. Recommendations. We did the echocardiogram to assess severity. Sorry, we looked at this already. We are now here. We said that if we have moderate to severe aortic regurgitation, we do an ECG to check if we have ventricular arrhythmias and assess the risk of collapse and sudden death in these cases. And now the ECG mustn't just be a resting ECG, we do an exercise ECG because we want to know, can this horse with this disease still be used as an endurance horse? Remember, this is an endurance horse. Okay. So we did that. This is a heart rate graph. You saw a little bit of a different one, but it's before, but this is basically the same. You have the heart rate here, and this is just every single heart. And you have walk, trot, then there was maybe a bit of a slower canter, and then there was a fast canter, and then there was recovery here. And you see all these arrows here point to these single dots here, so it's single fast heart rates. And these are ventricular arrhythmias. Okay? So if you look at the ECG itself, we saw, like you can see here, an abnormal, like you can see, these all sort of look the same. And then you have a fast beat that comes early, that looks abnormal. This is a ventricular arrhythmia. You don't need to be able to analyze ECGs. I just want to give you an idea how we do this. Okay, so we could say this horse actually had 19 single ventricular premature complexes and during an exercise test, so that is dangerous. Because exercise-induced ventricular arrhythmias, which we have in this case, okay, we consider these horses less safe to ride if they have them because there's a risk of sudden cardiac death. And horses with severe aortic regurgitation or with arrhythmias should not be ridden by children specifically or used as a lesson horse because of this risk. Okay, re-examinations, we can't do anything about it, no treatment, okay, we can just follow the case. We do twice yearly with moderate to severe aortic regurgitation because we know that it progresses usually faster. Okay, if there's no progression, then we do annual re-examinations. In this case, we said that the horse should only be ridden by informed adults, okay, that know about this risk, and that are saying, oh, okay, that's fine, I don't mind, I'm still going to sit on this horse. We said it should not be used as an endurance horse anymore, but should only be exercised at a low level. We said that there's an increased risk for sedation and general anesthesia if that is necessary, but there's no impact on the quality of life. I mean, the horse doesn't know that it has that disease, okay? And we said it needs to be rechecked in 6 months' time. I want to show you a video just to give you an example, an idea of what can happen and why we are so strict. Because people say, like, but I mean, the horse is fine. Like, why should we not ride the horse anymore now? I mean, like, we've been using it and it's performing well. Like, now I'm coming in and saying, like, sorry, the horse must be retired. Okay, so this is a funny, like you probably heard from my accent that I'm not South African, but I'm actually German, but used to work in Switzerland for a long time. And in Switzerland, they do something very silly. Once a year, they make this huge bonfire, right? You can see it's like probably like 10 meters high. And then they have like a parade, and then they have like horses that gallop around this bonfire. And it's like a thing that they like, so they have like a little mannequin up there that has explosives in it. And they light the fire here at the bottom. Okay, and then they take the time, how long it takes for this fire to reach the mannequin and like explode. And if it's really fast, it's going to be a good summer. And if it's not fast, it's going to be a poor summer. So they always do that in spring. Okay? And we as veterinarians always went there to obviously cover for the veterinary side of things. And I want you to look what's happening in that circle here. Okay, so like see these forces galloping around here, and then okay, see this horse collapsing and actually died. The rider was fine. I think it had like a broken leg or something, but the rider was actually okay, and the horse wasn't okay. Okay, and no one actually knew that the horse had anything, but we took this horse to necropsy, and we actually looked at the heart. We saw it had enlarged left ventricle. The aortic valve looked thickened. So it was very, very likely that this horse had aortic regurgitation, undiagnosed, and it just had like some ventricular arrhythmia, which we can't prove, we don't know that, but it's that likely, and it basically just died. And this is dangerous, we don't want that, and we specifically don't want that in a public event like this, okay? So that's like, for us as veterinarians, that's our job, to find these horses, say, no, they can't participate in things like that, okay? If owner goes and rides them in the field and that happens, that's their own choice. But like in a public event and on competition, definitely not. Okay. So this is why cardiology is important. Guys, do we need a break?